Here, colleagues, a big warm welcome to this session. It's the best session of the day, really, honestly. My name is Syed. I'm the head of policy and partnerships at the Special Program on Primary Healthcare at WHO headquarters. It's a privilege to moderate this session with my dear colleague, Zulfiya. And Zulfiya, did you want to introduce yourself?
Good afternoon, everyone. I'm Zulfiya Pirova, and I'm technical officer at the WHO European Center for Primary Healthcare, which is based at the birthplace of Almaty Declaration, which is Almaty. So we welcome very much, and we will be delighted to have you in our session. Thank you.
Thank you, Zulfiya. So this session comes dear to my heart, having led the work on quality of care at WHO headquarters for 7 years. And it's a manifestation of the key linkages that exist between performance improvement, quality of care, and the primary healthcare approach. And of course, the colleagues in this room are converted colleagues and recognize the critical importance of systems for improving quality of care and performance enhancement as part of a PHC approach. One of the things that we are really keen to do in this intimate gathering is to hear from the wisdom of colleagues. So we'll be, first of all, providing some keynote thinking related to the subject. And if I can just give you a flavor of how we're going to arrange this, precious time that we have together, we have a keynote presentation on PHC performance monitoring to PHC performance management by Dionne Kringos and Aleksandra Jovic. And then we will listen to 4 country colleagues reflect on a number of key questions. And then we will have time to hear from you all. So we're really keen to understand your perspectives, reactions to other country colleague perspectives. We're also very privileged to have reflections from Pavel Ursu, colleague from WHO headquarters, and Martin Weber, a colleague from WHO Euro. That's the overall structure, so we should relax. It's been an intense day so far, so I think we should relax, and let's try to use this precious time to the best of our ability. Zulfiya.
Thank you. And without any further ado, we would like to invite Dionne Kringos and Aleksandra Jovic for the keynote presentation on primary healthcare performance monitoring management and how it is linked to the quality. Dear colleagues, floor is yours.
Good afternoon, ladies and gentlemen, distinguished guests. It's such a pleasure to be standing here right after lunch. I'm so happy you are joined here. I hope you all feel re-energized because we have an important session here. This presentation is meant to set the scene. It will be a short presentation. I'll be talking here on behalf of our WHO Collaborating Center on the quality and equity in primary healthcare systems. And normally when I'm not in Kazakhstan, although it's a great pleasure, we are doing this work from the Amsterdam University Medical Center of the University of Amsterdam, based in the Netherlands. I will be joined in this presentation by Dr. Aleksandra Jovic, sitting here front row, on behalf of UNICEF, and together we will set the scene on the topic of the importance of primary healthcare management, its relation with quality improvement, and how it is conducive to drive towards better results overall for health systems. Quite loud microphone, but I hope there's not an annoying sound. So let's get started. We are confronted with a stark reality. Every year, millions of lives are being lost. Why? Well, mostly because of limited access to quality health services. People are not accessing healthcare, and those who are accessing are not always achieving high-quality health services. This is for a large extent avoidable, so that's the good news. There is hope if we try to improve the quality of our health services. we can avoid diseases like cardiovascular diseases, we can avoid cancers, we can avoid tuberculosis, newborn death, and maternal deaths. So there's a lot of countless of lives to be saved that can be avoided if we improve the quality of our health services. So the mission is very clear. The mission is that we should jointly collaborate in improving quality of health services. And it has to be a joint action because of the complexity, because of the multi-level approaches that are required to improve quality of care and to monitor our improvements and to make sure that that monitoring is embedded in our day-to-day managerial cycles. That's why it should be a joint action. Now, the fundamental question that we logically should start with is, what is quality in the context of healthcare? If you think conceptually, quality is the likelihood that health services will improve, well, it's the extent that health services will improve the likelihood of receiving desirable health outcomes. And it should be aligned with evidence-based professional knowledge. And this definition really includes the whole scope of healthcare services, from health promotion to its prevention, to its treatment, rehabilitation, and palliative care. And it also very importantly implies that we can measure the performance of primary health care and how it is achieving quality improvement. And we can actually continuously improve quality improvement, but it should be aligned with evidence-based service delivery so that we avoid avoidable diseases and we are accountable for the quality we are reaching. Over the years, we have come to identify what are the core elements of quality of care, and you see those depicted on the slide. So there is large international agreement that what high-quality healthcare services is. High-quality healthcare services are those services that are effective. They are effective by providing evidence-based health services to those who need them the most. So it's aligned with the needs and preferences of patients, families, and communities. It is the health services that are safe by avoiding harm to the people for whom the care is intended. It's health services that are people-centered. It is oriented around the needs and preferences of those you are caring for. But it should also very importantly be timely by reducing waiting times so that you don't have harmful delays in receiving care. Importantly, it should also be equitable. It's about the distribution of services by providing the same quality of care regardless of individual characteristics or beliefs or opinions. It should be well integrated. We've just had a very powerful parallel session about the importance of integrating the core functions of public health and primary care services. And it, of course, also should be efficient by maintaining the benefit of avoidable resources and avoiding waste, so that we are mindful of the scarcity of resources that we are having to deal with. But the complexity of it all is that quality is not a given. It is not an inherent feature of our health system. No, quality of healthcare is the result of deliberate processes. It requires clear vision, a commitment, leadership, investment, but also the caring, compassion about the patients and their preference and need. But it also should be accompanied by rigorous monitoring of the extent that we are actually achieving quality. And quality initiatives should really be implemented across the different levels of health systems. It should be at the national level. It should be geared towards the regional, the district level, the facility level, and all the way down to the furthest, smallest clinic that you have in the countries. And it was powerfully said, of course, also by the DG of WHO. And this implies that action is really needed in order to continuously make sure we're on top of improving quality, we're accountable towards that. Now, in order to know how well the quality of services are, we need performance monitoring, and that measurement of performance of primary healthcare should be embedded in our day-to-day managerial cycles. But we should be aware there are different purposes for which you can use performance intelligence on the quality of your healthcare services. And they're both all very useful. You see them on the slide. It can be used to identify the areas where we need to improve quality of care. It can also be used to inform monitoring progress over time. Have we actually achieved the impacts that we were aiming to achieve with certain initiatives? It can be used to nurture quality culture of transparency about quality of care. You could also use it to benchmark achievements across facilities, across districts, or across countries. And you could powerfully also use it for managerial purposes, such as informing your resource allocation. So it's very important that quality initiatives are accompanied by performance measurement embedded in performance management cycles. And in a bit, I will show you the WHO UNICEF operational framework, and it offers you evidence-based interventions. We know what to do. It's now about the implementation. So there are evidence-based interventions that are ready to be applied at the different levels of our health systems. But we should be mindful that once we are planning those, they should be targeting at least these 4 core components. They should be targeting the health system's environment by, for instance, nurturing the quality culture and make sure that the workforce in primary healthcare is equipped to actually improve quality of care and to be aware about the importance and how you can change it. It should be targeting reducing harm, for instance, by setting standards, supporting patient safety mechanisms. It should be targeting clinical care processes by introducing clinical pathways, supporting clinicians with shared decision-making process and clinical support tools. And most importantly, it should also be accompanied by targeting, engaging the patients, the families, the communities, by empowering them, addressing health literacy, supporting them in actually employing shared decision-making. So the good news is there are evidence-based quality interventions available, ready to be used. Now, if you want to monitor the progress of your achievements, the WHO UNICEF operational framework offers you a fantastic instrument where it shows you the linkages that Shams was saying. It shows you how health systems improvements that you see on the right side of the slide are linked towards the action, the actionability, what you need to be done, the strategic and operational levels of which quality improvement systems are part of it, and how that links to the core pillars of the primary healthcare approach, the multidisciplinary care teams, the integrated care, the empowerment, etc. So this framework offers you a toolbox, very many support and guides on what evidence-based interventions are available. And if we unpack this operational framework and we show you the monitoring framework it has available, there's a whole world of indicators that are ready to be used and applied across the system levels. And what it can help you to do is to actually monitoring the capacity of primary healthcare in order to set the right conditions for improving quality. It offers you to monitor the performance of primary healthcare and the impact on outcomes and desired areas of health systems performance. And this is a whole world of many indicators, but you should always be aware for what purpose am I wanting to measure the performance and link it to that. And that is, for instance, shown on this example slide. It shows how can you measure, for instance, in the area of non-communicable diseases, whether or not we're achieving progress in access and quality of NCD services. So it shows you will need to adapt the governance of your system, the financing, the workforce capacity, and there are indicators for those for you to measure that. Now, very importantly, what you should be aware before you start selecting how to measure it is at what level of the health system am I targeting my quality interventions? Who are the users of those interventions? What information needs will they have? And how can I actually make sure that our health information system in the country is supportive for the measurement objective in monitoring the impact of primary healthcare services? So always be aware about the fitness for purpose and use of your monitoring initiatives linked to quality improvement strategies. Now, given the complexity of this all, at WHO, we are really committed to supporting country teams on how to improve the measurement and management of primary healthcare performance. So our collaborating center in the Netherlands is actively collaborating with the European Center for Primary Healthcare in Almaty to support country teams in their own improvement projects. So since 2021, we have been supporting 17 country teams, about 6 teams every year, through coaching sessions, through training weeks, through one-on-one interactions, and creating a learning community across countries. And they each have then, in such a country, in a year, they have defined their own improvement projects, get guidance, And based on that, we always stay in contact with the country teams to support them in building capacity on how to improve your quality improvement interventions. With this, I would like to give the floor to Aleksandra to take it over. Thank you very much.
And the next part of the presentation is, while a lot of things is already in place, we also face difficulties in implementing them. So we'll try to shed a bit of light on, what are those difficulties that are preventing ministries of health, the overall systems that are providing healthcare, to improve the quality as a continuous improvement process. You will recognize that a lot of these challenges are actually very much mirroring the strategic levers, because as a first one, the lack of financial resources and investments in staff, and we have heard many times already today that we are suffering from the staff shortages, but the overall investments in the primary health care, and that they come from the political commitments. Wherever the political commitment is lacking, the investments will be lacking as well. The lack of infrastructure in terms of the facilities, physical infrastructure, but as well the lack of digital technologies that we also know can really improve the quality is the fourth of the challenges that the countries are facing. In terms of geographic access, we still see the challenges of both improving the quality of care from the access and quality in rural areas where the physical accessibility is the problem, but also in densely populated urban areas, like we heard the example of Iran in another session today. Where policies are inconsistent, where the governance is lacking because of lack of will, because of corruption, because of lack of attention and communication between different levels on the policy and governance, it will be very difficult to implement the quality improvements, and particularly in a consistent manner. And you have heard from Dionne that data management is at the heart of the quality improvement processes, and there are so many different sources of data and indicators that without improvements of the data management system, and equally importantly, health information system that are digitalized and not paper-based, again, the progress will be slow and it will be very difficult to monitor the progress. Limited patient involvement will influence the quality improvements in the sense that there will be lack of understanding of actually what are the patient and people preferences and demands in terms of the quality of care, so that the take-up of services that are not people-centered and sensitive will not be the same. There is also a limited understanding on how quality of care efforts can and should be integrated and really mainstreamed in all the different efforts that are in the health planning processes, in the implementation of the improvements, and there is no difference between improvements of the quality of care and access. The quality of care should be integrated in every aspect of the health planning and expansion. In terms of monitoring and measurement of the different aspects of care, we also wanted to shed a bit of light on the aspects of quality that are very important yet difficult to measure. So the fact that for some of those that I will mention, we don't have the appropriate tools, but it doesn't decrease their value, and there should be efforts in place really not to forget about the aspects that are not so easy to monitor. And we are starting with the patient-centered care, and we have again heard today from the nurse from Norway how difficult it is to find time to really talk with the patient, to communicate, to show compassion and empathy. And patient-centered care is indeed very, very important element of the quality of care, yet not so easy to measure and define indicators for it. Cultural competence as well is something that we expect from the health workforce that enables them to deliver health care in a way and with the approaches that are culturally sensitive and acceptable for the population. But again, measuring to what extent our health workforce is really culturally competent presents another challenge. In terms of patient-reported outcomes, you are aware that they are that can be biased, they are prone to subjectivity, so that presents another challenge. as well as long-term outcomes that can be influenced by many factors, and not only, and as the time passes, the larger the number of factors influencing them is. Timeliness, we can measure in terms of geographic and timely access, but while we usually measure geographic access only in terms of proximity, we don't necessarily take into account other factors that influence access, such as transportation, means, cost, availability of it. And timely access, not in terms of only patient waiting lists, but also appropriateness of the care that is provided in terms of the healthcare urgency. Integrated services we saw, that is one of the important elements, but it is not so easy to measure to what extent are services really integrated, both vertically and horizontally, particularly if the systems are fragmented and if the monitoring systems are weak and inconsistent. In terms of equity of care, again, something that is very, very important, but health disparities, the extent to which we can measure the health disparities in terms of the outcomes for different populations, but can we really effectively measure to what extent the quality of care is impacting those health disparities is another question. And we know to what extent social determinants of health impact health outcomes, but again, to measure really the impact of social determinants to the health outcomes, in a consistent manner is not so easy. And finally, holistic and preventive care is one of the important elements of the primary health care, but we are faced with a lot of difficulties when we want to measure its effectiveness. To what extent are the services that we are really advocating for, and as someone who is working for UNICEF, advocating for a lot of preventive services for children and women is at the heart of our mission, but proving their effectiveness is not so easy, and finding indicators that will do it. The same for the health promotion. Finally, there are some closing messages that we should take with us leaving this presentation, and they start with a request to all of us to ensure quality is woven into fabric of the PHC-driven efforts towards universal health coverage using a multifaceted and measurable approach, all the indicators and all the frameworks that are already developed and in place. People need to be in the center of our efforts. And we say people, we mean also patients, but as well as health workforce that needs to be empowered, trained, and fully in support of the changes that are resulting in a better quality of care. Equity is not going to happen by default. And we need to invest really a lot of effort and attention to ensure that the quality of care is reaching everyone in the same manner, irrespective of any kind of personal background. And given that quality changes are expected at all levels and by so many actors, coalitions are equally important within the health system, but also with the communities of patients that we need to empower and engage. We need to also, in every country, we have heard the frameworks are in place, but the countries have to adapt them, nationalize them, understand their local context, and really make the solutions locally relevant and feasible. Compassion is the main ingredient. It should be at the heart of our choices to become health workers. But it shouldn't, again, be something that is default. It should be nurtured. Its importance should be, reiterated through different occasions. And the time and space to show compassion should be made for the health workers to be able to exercise it. And finally, although we have SDG targets until 2030, you will all note that, the time is passing very quickly, and we have heard today a lot of reflections that we are not moving as fast as we would need, even to reach the SDG targets. Finally, there are a few key messages with which we would like to conclude the keynote presentation. And they start with the fact that operational framework is in place. And it is a huge opportunity, so we don't need to start from scratch. There is a guidance, there are indicators, there are metrics that the country should use, adapt, and run with if we want to create a difference. There are also evidence-based interventions that are based on evidence. So again, not something that we don't need to reinvent the wheel. They are effective, they are efficient in terms of also resources required. Actionable indicators for monitoring of the progress are in place. They enable, monitoring of all the different aspects for which you will see that your country needs it the most. System health information systems are vital. Running the paper-based systems or, systems that are not really covering all the elements of the health systems and elements of the quality of care will not be sufficient. And as you saw, they need to be available at every level of healthcare, from the smallest rural unit to the Ministry of Health. Data analysis is the next step. If we have a lot of data and nobody is looking at the data and using it for policy making, it is futile. Strategic levers we have mentioned as challenges, as enablers, so nothing will happen if there are, if we are lacking on them. And finally, contextualization, in which the quality of care efforts require adaptation to the context that are making country experiences of fundamental importance. And we are looking forward to hear country experiences in the next part. Thank you.
Thank you very much, dear colleagues. If there are no immediate questions at this point, we propose to move to the second section, which is hearing from country experiences, as Aleksandra rightly mentioned. So we would like to invite our panelists and experts to proceed to the podium. Take the chairs, please. Yes, come in. Yours too, yeah, please. Martin and Pavel also. Yeah. You can listen here as well. Yeah. I think that in all the parallel sessions we give quite challenging tasks for our panelists and experts, reflectors. We are giving a very short time, and we want to hear great thoughts. So this is the reality we have, and that is why we have to organize ourselves as effective as possible. And without any further ado, I would like to invite Jelena Jankovic, Assistant Minister of Health of Serbia, to share Serbia's experience on improving the quality of care. We know that Serbia has demonstrated quite an improvement in the quality of primary care through strengthening family medicine and multidisciplinary approaches, which will also in turn help to enhance equity. Would you please elaborate what key interventions you applied to achieve these results? Floor is yours.
Thank you. Good afternoon to all. In my name, in the name of Minister of Health of Serbia, and also my country, Serbia. Again, good afternoon. I would like to say that primary health care in Serbia, we must say that we have universal health care, universal health insurance, as well as we have health for all in primary health care. Main pillars in primary health care is prevention of non-communicable diseases, immunization. Also, I must say that regarding prevention, non-communicable diseases, Serbia made many programs, national programs for prevention of cardiovascular diseases, diabetes, cancer, and as well we provide screening on breast cancer, cervical cancer, and colorectal cancer. Regarding immunization, we must say that main holder of immunization is, of course, primary health care. And regarding COVID-19, primary health care was the main holder that provide immunization, testing, and treatment on the beginning of disease. I must say that we have a good example, a good practice in Serbia, and thanks to UNICEF, Serbia provide very useful program for family-oriented childhood intervention. What it means? It means that focus is on families, focus is on people. So we moved all focus in a family, that we have provided many trainings for home visiting nurses, and also pediatric services, that they visit each home, every home, with idea to provide education and support of parents to include them in developing process, in developing monitoring and early detection with developing problem with children. We provide so much training, and home visiting nurses come to each home, speak to parents, speak to family, and support them to follow the developing of their children. We think that is very important because it is possible to visit every family, to be in a natural environment, home, preschool, and also we are proud that in this process we include all intersectoral cooperation. For example, we include preschool services and include social workers as well. Our next challenge, and we think that is very important for Serbian primary health care, is to strengthen mental health programs, especially for children and youth. We think that mental problem has epidemic dimension, and our new challenge is to strengthen capacities in psychologists, to increase number of psychologists in primary health care, to make education on pediatric, how to early recognize the problem of mental health, and how to advise young people or children or their families to solve the problem. It will be our next challenge. We have support from WHO office in Belgrade and also support from UNICEF. We started with 7 municipalities, and we hope that we will have results by the end of this year.
Thank you very much. Yeah, thank you very much for sharing your very interesting experience, and I think it's especially interesting for the countries who are on the pathway of building this people and family-centered care. And we talk a lot about health, but we also know that health, good health lies far beyond only health sector, and that is why reaching out other sectors is a very important aspect in building comprehensive care, and as well as strengthening capacity of the primary care providers. All these are quite important elements when we talk about quality and comprehensive care. And next, I invite Shams.
Yes. So, Aliaksei. Aleksandra Shcherbinski is the head of the main office for the medical care assistance in the Ministry of Health in Belarus. And this question is really focusing in on quality and accessibility. So quality and accessibility are the most important characteristics of primary health care. Well, what successes and lessons can Belarus share in this direction?
Thank you. Good afternoon, everyone. I was going to make my report in Russian previously, but I see that majority of you have no headphones, so I will change slightly my plan. So, we have common problems in each country, and in general, we know how to make solution for it. But depth of each problems is different. Why? We have different economic models, political vectors, different system of health care. One of it, for example, for budget, and other for insurance. But we have and local problems, different geographic area, different structure of population, and others. So I will share now about our experience to to change these problems, and I will share our experience of improvement of these aspects. At first, we have state program for development healthcare, and we renew this program every 5 years. Secondly, we have state program for improvement digital resources in our country, and now we have the main goal. It's to make a loan medical information system. At third, we try to improve our financial state. For example, several years ago, we have about 40% for PHC. But now we change this situation, and now this percent is about 50%. We know that optimal models looks like 40% for hospital sectors and 60% for PHC. But nevertheless, we have one-to-one at now. Next aspect, it's medical personnel. It's a very important aspect, and now we have no enough medical personnel, but every year we try to improve the situation and to make more, to learn more students and to make more doctors. And at last, the most important aspects that I want to speak, it's our availability for rural population. We try to improve medical health care for this part by improvement quantity of mobile medical complex and for increase ambulatory in rural area. Thanks.
Thank you so much for really elucidating some key points on the state program, the finance for PHC, the medical personnel investment, as well as a focus on rural populations. Thank you.
And I'm pleased to invite Mr. Naod Wendrad Abera, Lead Executive Officer of the Strategic Affairs at the Ministry of Health, Ethiopia. Right now, a few minutes ago, we heard about the WHO, UNICEF, PHC performance monitoring framework, and I think that we are lucky to hear from you, from your implementation experience. What were the 3 main actions taken by Ethiopia to enhance PHC performance using the framework which I mentioned? Floor is yours, please.
Thank you very much. So, my name is Naod from Ministry of Health, Ethiopia. I'm Strategic Affairs in Ministry of Health. So I will give you some background about Ethiopia. Ethiopia is found in northeast of Africa and a population of more than 110 million, with estimation 2003. So in PHC is the major policy background for the policy of the Ministry of Health in the sector. So specifically, we perform PHC in the last 20 decades, and we improve most of indicators specifically set in Millennium Development Goal and SDG goals. Specifically, we improve life expectancy from 50 to 68, and maternal mortality reduced from 400 to 267, and under 5 mortality also decreased to 47 per 1,000 population, which is a lot of improvement are shown in performance, PHC performance. This is based on the 2 basic components. The first one, the health post in the country, and also the health extension workers doing their best in the community level. That is the first one. The second one is health center working on in the community. That is the most nearest health service, curative and prevention. While we are doing this, we said most of health performance monitoring tools are introduced in the health sectors, and we specifically try to monitor this performance monitoring. And we try to align also the existing PHC performance with WHO UNICEF performance framework. In this regard, we do the first thing, align, we try to understand what is this framework and also the existing one in the country. So we try to align objectives and indicators, and we customize with the context of Ethiopia. So I think there is a 14 objective in the framework. We make it 60 with the context of Ethiopia, with some modification in some indicator, with some modification, with accepting some of them as it is. So we are doing that, and we try to do the gap analysis, specifically what information do we have to measure this performance on WHO, UNICEF performance monitoring evaluation, and we try to have a baseline assessment. Specifically, the Ethiopian health information system relies on two forms of information, survey and routine health information system. Survey are so costly, we cannot do it every 5 years and 2 years. And you know that the context of Ethiopia, there is conflict, there is drought, something. Sometimes it's a challenge on health information system in survey. But the routine health information system is good, so we are using that. In the routine health information system, we are implementing DHIs to more than 95% of government health facilities, and also we are introducing the community health information system, which is digitized, ECHIs we call it. And these ECHIs, we have more than 80,000 health posters in the country. And these 80,000 health posters, out of these, 1/3 of them are implementing ECHIs, which is a community-based family folders introduced in the health facility. So we are using those data, analyze the baseline for the specifically WHO, UNICEF performance framework. So we are doing that. Specifically, we have a challenge. Specifically, digitization is still the challenge due to access of connectivity and electricity and others in the rural and periphery of the health care. So we are doing in this way. Thank you.
Thank you very much. It's very interesting. Just for the sake of the time, I would reflect on two things. Contextualization is very important. Yes, we have this framework. It is great and huge, but what specifically can be used for the purposes of the country, it is very important. Tailoring to the country context. And the second, yes, data, surveys, data, strong information system. We need data to do the gap analysis. We need data to inform our decision. Thank you very much. It was very interesting.
Abdifatah. Abdifatah Ahmed Mohamed is the Director of Policy and Planning in the department at the Ministry of Health and Human Services in Somalia. And we heard the importance of packages of services in many of the discussions throughout today. Abdifatah, could you explain how a national service package in Somalia underpin government efforts to improve quality of care in a PHC-oriented system?
Thank you so much. First of all, I'm very delighted to be here today and showcase the essential package of health services for Somalia and how it tends to provide quality of care in Somalia. But before that, in 50 seconds, Somalia is a country unique with its needs, challenges, but again with its innovative ways of coming up with solutions. You are aware that Somalia did not have a system for over 30 years. So the essential package of health service for Somalia, the EPHS, was the start to put the country in the right direction and into the path of providing high quality, evidence-based, contextualized, and cost-effective primary healthcare oriented services for the Somali people after a long time. With that, I say, because after the collapse of the Somali government in 1991, there were no services that were provided by the public sector. the services were provided by NGOs and the private sector, as such fragmented and not primary healthcare oriented, mainly, sorry. So the essential package of health services for Somalia, now we have the second version, which is the 2020, is allowing the government to provide primary healthcare services that are based on the needs of the Somali society. So it is a framework that's now being used by the NGOs, by the government, and by, to a certain extent, the private sector. It also allows the government to roll out the services which are primary healthcare oriented in phases. And I say that because it allows the government to use whatever resources that is available for the sector, because resources are very limited. And in these rolling out phases, we can implement high impact, cost effective and evidence-based services that the Somali society needs. We also focused on building the health information sector by moving from paper-based to digitalization of all the patient records and providing DHSI2 tools to all primary healthcare facilities in the country. And this allows us to monitor what services are happening at each level of the essential package of health services, because the facilities in the country that are run by the NGOs and the government can be monitored through the gathering and the collection of routine data. So this allowed us to put the country on track towards to achieving the universal health coverage, because the essential package of health service is the sole framework for service delivery throughout the country. Thank you.
Thank you so much. And first of all, salute to your efforts in what an incredibly challenging environment, and recognizing that even within that environment, the package of health services and actually organizing the thinking around the needs of the population and embedding quality of care issues within the design and the implementation of that package of health services. Thank you so much, Abdifatah. As usual, time is short, but we would welcome, before turning to our expert reflectors, if there were one or two perspectives from the floor, we would welcome that. Are there any points that really are burning that people would like to share? Are there any questions that you'd like to pose to any specific colleague? The chance is there. The window will close and we'll go to the experts. But if there are any burning questions, they're welcome. We won't oversell the questions unless people are burning with a burning question. Let's turn to our experts. We're very privileged to have two colleagues here with us. So turning, Dr. Pavel, you heard the four perspectives, you heard the technical injection from colleagues, and I know that you have a very strong focus on delivery for impact, being the director of delivery for impact at WHO headquarters. Turning to you.
Thank you very much, Shams. And I perhaps will take a few steps back or maybe zoom out a little bit, just to appreciate how important it is that we are meeting these days to discuss primary health care with focus on implementation and focus on driving for better results. And I think it's very important to appreciate that as much as we are concerned about planning, identifying the right strategies, looking at the evidence, put in place the plans, this is only the beginning of the journey if we've done that well. And implementation is hard. So it's just to really, really appreciate that all the examples from Belarus, Ethiopia, Somalia, but many other countries are really, when the rubber hits the road, when we're talking about implementation, somehow the energy, forces, enthusiasm tends to really, really slow down, and somehow the focus is shifting. Sometimes there are additional problems tricking into the implementation, and keeping that focus is really, really very hard. So there is no surprise that we are, after 45 years of Almata, we are still kind of struggling showing that, linear success. And we are talking about acceleration. We are talking about acceleration also from the perspective of the SDGs, which was a heavy process to build political commitment based on technical agreements. What looks good for the world in 2030? What are the main indicators through which we will judge the success of the SDG era? And we are talking now, we are in the middle way, middle journey for the SDG 2030, and we see that we are quite off track to reaching those targets. We always understand that some of them are quite aspirational, but this universal agenda created a political commitment, and this political commitment has been also backed up with a number of political declarations, with a number of very important meetings. Yet that creates a good environment for action, but doesn't create the action, by themselves. So you just appreciate that implementation part is the most difficult. And when we reflect sometimes in the groups, when you take the bandwidth of achieving results, what would be the right balance between planning the design and effort for the implementation? And I think there are a lot of convergence in the fact that 90% of your time, of the bandwidth, has to be in implementation and refining the plan and solving the solution, solving the problems, coming up with the solutions, and making sure that we are getting on track for that trajectory. So now coming back to very concrete problems which I've heard myself during these discussions, is that the context is important. We are really looking at the context-specific solutions. It is also very clear that the operational framework for PHC, the PHC measurement framework indicators, really gives us much more opportunities to somehow standardize and focus. I think there's still the issue of really choosing few interventions versus choosing many interventions, because when you start with too many, it's very difficult to really put the right focus. And I think that we all struggle with that. But at the same time, I think that the PHC measurement framework and indicators really allow this flexibility, allow these choices for the countries to really look at the impact which the countries are trying to achieve in a holistic way, looking at what would be the intermediate results, what would be the activities, what would be the inputs to address that particular problem. I think that gives really a very unified way to progress towards that acceleration which we want to achieve. So from that perspective, I just make a parallel that when we are discussing in the context of WHO in delivery for impact, we are looking at the model which is very, very compatible with the quality, performance, and improving performance through quality, which is really looking at the very structured approach in iterating, analyzing, looking at the problems while implementing. And this is how the progress is really generated within implementation. So I think that this is something which I'd like just to highlight, that plans are extremely important, but when we start implementing, there is always a new reality from the day one. And it's really very important to build that culture of reviews. We call them management reviews when we're talking about in the context of the accelerators. This is exactly what we're probably learning from the quality interventions or driving the quality, is that exactly if you don't spend enough time to analyze how your particular plan is being implemented, if you don't have the intelligence from the data, which gives you the understanding whether you are progressing as you planned or you are facing a problem, if you then don't follow with a very, very agile problem solving, making sure that you have the right stakeholder to help you to unblock a particular bottleneck in your plan, then you will be stuck, and then you will not have enough attention to progressing to that. In addition to that, I would like to say that we strongly believe in data, of course, from the premises that as we all know, Edward Deming was saying that, you know, in God we trust, but for the rest, show me the data. It's not that extreme because we know that not everything can be measured, but I think if you also cannot measure, you cannot demonstrate impact. So we really have to make sure that we have the data systems and we can improve them meanwhile. The truth is that we cannot wait until the data is perfect and spend all the time to fix our data system and then move to the intervention. It's pretty much doing that in parallel, but even more so, the data has to really fit the purpose of what you are trying to do, what problem you are trying to solve. And I think that here you can get that agility by making sure that your monitoring efforts are really purpose-driven rather than driven by a need to report or a need to just really put a number somewhere. So there should be no really monitoring efforts if they not result in improving. So I think that we should really look at that in a very pragmatic way. We cannot collect all the data. We cannot fix all the data system. Digital is helping us to be more agile, but we need also to bring selectivity when we are trying to really focus on a particular one problem. And I think what is important here is also in the context of the accelerations and acceleration interventions, I think, as I said, bringing the culture, because once the team and teams, I would say, because we are not talking about a team, we are talking about central level, regional level, district level, and very local provider level sometimes. I think what's important is that once this culture starts to be a routine, it helps to look at the problem solving in a different way. It helps to really apply the same skills across other relevant topics. And when I'm talking about primary health care, this is exactly what we need, to reach out to those relevant stakeholders, to bring them together in a meaningful way, and to make sure that the improvements at the local level are fed up, are translated into the actions to the regional or the central level, and central level take note of that, and they use that to benefit the policy, while at the local level creates a strong culture of improvement, quality improvement, and addressing the problem. So I think that once the problem is clearly identified, and then the right efforts are in place with the right people to solve the problem, this is the recipe how you can apply that for the next problem which can appear. And I think maybe the last one is definitely not to forget that the primary health care providers, they work for population. And I think I've heard a lot about the platforms, the way that people can really shape that expectations, shape and tell what they like, what they don't like, what they would like to see. I think that's very important input to all type of improvement interventions. And the other one is really what we've discussed yesterday, the political economy. So how can we really also make sure that we communicate to the political level in a way that we are getting the backup, we are getting the support for the next round of improvements, because there is not static. We will need to make that level increase, level improvement once we reach a particular target. So we will revise and we'll make it perhaps more ambitious. So we will need the backup of the political economy stakeholders to support the quality improvement interventions. I'll stop here.
So much, Pavel, and bringing in the science of implementation in synthesizing for us from the country experiences. Martin Weber is the head of the Athens office for quality of care in Euro, decades-long experience in quality improvement and quality of care. Martin, when you've listened to the proceedings, what are your reflections?
Thanks very much, Shams. And I realize we are at -1 minute by now, so I'm sure you are starting to walk out in the middle when I'm talking. So I will make a few pointed, provocative statements to try to keep you, because you might want to reflect on some of them. I mean, I think it's a given that quality of care is at the center of primary health care, but that it's very often not delivered. I heard the statements from Ethiopia and Somalia, and I think it's a bit of a different issue whether you are building up a health system to reach populations at all, or whether you have a relatively matured health system which you want to reorient, as you very often have in the European region, where you would try to reorient existing health system more to primary care. And this sort of transition, of course, is extremely difficult because you have lots of vested interests there, and you have perception of the population. What is good care? And if you have a perception of the population that the place where you should get care is the hospital, and everything else does not matter, you obviously have a major problem, because you have to try to reorient them. And for doing this, you cannot push. If you have a piece of string to get people around, you cannot push with a string, you can only pull them around. And this is the sort of thing where you have to try to convince them that the quality you provide is good at the primary care level. And that won't be done in a day, it won't be done in a year, that will take a bit of time. And you have to build up your facilities, you have to build up your workforce, they have to have the competencies which are trusted. And for this, I want to do a bit of self-advertisement for a change. For the European region, we have produced a pocketbook of primary care for children and adolescents, which is basically summing up the competencies which we believe a primary healthcare provider should have to deal with the conditions of children and adolescents. And particularly adolescent health is an area where we have a problem all over the world. I mean, every parent has a problem with adolescents, so why should the healthcare provider be different in this regard? To address the problems of adolescents, take specific skills and competencies, take specific training in it, and if this is one of our indicators which we should have, whether a healthcare provider can do this, this would be the one I select as an indicator. We have to listen to patients. Patients' perspective, patients' voices are important, and we are getting some information from the Patients' Voice Survey, which has been promoted by Margaret Krug, which gives us insights, and it very often tells us that people trust in private provider, but they don't trust in the public system. And that basically means we have to do something around it to try to make the public system more trustable. So that's the one point I wanted to make around this. I don't have much time to go into much more detail, so let me just make one more point about the monitoring. I heard it from Dionne, I heard it from Pavel. I've been working in quality of care for over 20 years, and we used to say what is monitored, what is measured is done, what is not measured is not done. If people don't document it, it's not done. And having said this for years, we have a health workforce who is fed up with the bureaucracy. Some of my colleagues have left the profession because they say we are doing 30% documentation nowadays. I want to talk to my patients. I don't want to do so much documentation. So we have to be very careful with the monitoring, that we don't overdo it. We have very selected indicators which help us in the process and which look at problems. And here I want to make the statement again, which I started off with. We have to look at the problems, the perceived problems. We have to get them from stakeholders. We have to get them from patients. What is the problem in your health system? Is it access to care? Is it the effectiveness of care? Is it that the primary care provider only refers anyhow, so why should I go to a primary care provider? And once you have these problems, try to address them. Select one indicator or two, and monitor progress that you have improved the situation afterwards. So that's my -3 minutes, which I was using here.
We're going to use a few more minutes because people are really keen to hear from colleagues. And I'm actually going to break a bit of protocol here and come back to the country colleagues. It's a rare opportunity to listen directly from the country colleagues. One thing that you wanted people to walk away with from the conversation that you've heard. Very rare to have colleagues together talking about primary healthcare performance management and quality of care. We've heard very beautiful connect points from each of the 4 countries, but if you had one message to emit to the world, and we'll just go in the same order, what would that be?
Our message from Serbia is Our message from Serbia is that our main goal in Serbia is that quality of healthcare should be 80% covered by primary healthcare. If we provide it, we will be very happy. So we are going in that direction. Thank you.
Please, sir.
Thank you. Our message is next. As a rule, we have no enough resources. So we should to make our tell it's better organization, more better organization process.
Fantastic.
My message is for data use for continuous quality improvements in the each stage of the health sector.
Fantastic.
Well, I think mine will be a bit radical, and I would say that in implementing high-quality primary healthcare services, countries like Somalia with a lot of challenges can also teach you a lot of lessons. So learn from our essential package of health service, which is actually evidence-informed, primary healthcare-oriented, and context-based. So we can teach innovative lessons to other countries.
Fantastic. There are 4 clear, poignant messages that we can walk away with. And one of the things that these sessions allows us to do is to move from theory to practice, the whole theme of today. So what we've heard, the wisdom from Serbia, Belarus, Ethiopia, and Somalia. But of course, there are many other examples, many other experiences that we need to foster. You will have seen the report that WHO and our colleagues in Euro Health Observatory have launched today related to the evidence from countries, the experiences from countries. We urge you to take a careful look at those because there is nothing like country wisdom. Before handing over to Zulfiya to close, just maybe one particular point related to this measurement improvement nexus. We've always highlighted in all of the work that we've done in quality of care that there should be no measurement without improvement. Weighing a cow repeatedly is not going to enhance the size of that cow. The cow needs grass to eat. So often in our systems, sometimes we measure without connecting it with improvement. And of course, there can never be any improvement without measurement. That nexus is really important for us to walk away with. Wanted to thank particularly Pavel and Martin for their wise words of wisdom. The WHO Quality Toolkit is a web-based toolkit that brings together all of the resources on quality of care for use for implementation. I urge you to have a web search of that. It may be helpful in your efforts at the country level. Please.
Honestly, not much left to say. I just want to thank you very much, everyone, for joining this session. And one very, very interesting session is ahead, ahead of us, and that is why, without any further ado, we close this session. And thank you very much for your interest and participation.